I don't have a.
This is pretty good.
It'll just completely jack my battery. I'll be dead.
I've got 2 batteries.
It'll probably help a little bit once he sits down and see his face.
I don't think it'll affect a lot once it's on.
No.
It's amazing these LED lights now. They
I
don't
know.
burn up like they used to.
So nice.
Jerome? That's later. Even though they'll be done by the time I get through this together. But I've asked for an interview with Senate leadership for a little something. A little I don't think there's anything happening today and I talked to the virtual and he said there's nothing.
Hey, good morning.
Good morning.
Thanks for coming on Thursday. Let's see. Give me 1 second here, guys. Okay. We ready? Yeah, 10 o'clock. Okay, good. Let me unmute. Hey, good morning, everybody. It's 10 o'clock. We'll go ahead and get started. Just as a reminder for you guys who are calling in, I think we got our phone issues fixed from last week, so please try to stay on mute if you would to minimize your background noise. Hit *6 to unmute yourself and ask a question, and then *6 to mute yourself again if you're not speaking. So we appreciate you guys making time for this. We had a little bit of a scheduling conflict tomorrow, so we're doing it on Thursday this week. So thanks for participating. Again, this is really just for you guys in the media, and so we're happy to do this as long as you guys find it helpful and want to have this forum to ask questions. So just a few items I wanted to go over with you. Please remember that Alabama now continues to include as an eligible population our Phase 1A or Phase 1B, and then also dropping down to Phase 1C just only for the group of people 65 years of age and up. That is somewhere more than 1.5 million people still. And 1.5 million people require 3 million shots. And so we are doing our best to get this group vaccinated as quickly as possible. We will start this coming week getting somewhere an average of around 90,000 shots, between 90 and 100,000 shots per week is what we anticipate. That's not counting anything that may happen related to J&J. We're still waiting on more information on that, so that number could be higher depending on what happens with J&J. I guess I can go ahead and mention that at this point, I guess. Johnson & Johnson, as you know, there's been a recommendation from the FDA advisory group to the FDA to issue emergency use authorization for this product. The FDA is going to make that decision in the next day. It's anticipated that they will grant authorization. And if that's the case, the VRPAC subcommittee of the ACIP will meet they're the advisory group who looks at these data on behalf of the ACIP. They'll meet to make a recommendation to the ACIP, who will make a recommendation to CDC, and then the CDC will make their own recommendation. So we think we'll probably know about J&J in the next three days or so, hopefully by the first of the week. Just for you guys, we've been asked this question a lot. The J&J, Johnson & Johnson, is a U.S. company that owns Janssen Pharmaceuticals in Belgium, who's making this vaccine. And so sometimes people say Janssen, and sometimes people say J&J, but that's the same product that we're talking about. The J&J vaccine is a one-shot vaccine, as you know. It is much easier to handle in terms of its cold chain. One shot opens up a lot of doors for us, and there are a lot of logistical problems that get solved by having a single dose vaccine. I want to talk about the efficacy of J&J because we get asked about that so much. In the United States, the studies J&J did showed that their vaccine was 72% effective in preventing infection, compared to 95% effectiveness by Moderna and Pfizer in terms of preventing infection. However, in terms of preventing serious illness and hospitalization and in preventing death, they're all three equivalent. They're all three, in fact, identical. No one who got J&J vaccine died from COVID. And in fact, no one who got J&J vaccine had a serious allergic reaction like we've seen with the mRNA vaccine. So I think we really want to get the message out to the public that we are very confident that this vaccine is going to be shown to be safe and effective and equally valuable, just like the first two. I know there have been stories that have focused on that 72% effectiveness number, and that is not the message we want people to take away. This is a vaccine that prevents deaths and prevents even serious illness and hospitalization at exactly the same rate as the other vaccines. And so the best vaccine to take is the one that you have offered to you. Please don't shop for them, and please don't wait around because you think one's better than another. Maybe someday we'll have a vaccine that's we recognize is not quite as good, but this is not it. This vaccine is equally good to the two that we have already available. We don't know about the numbers of J&J. There have been reports in the media that we've seen that say there's 2 to 3 million doses available, ready to ship. That's strictly come to us through the media. We've not had any official notification of that at all. We do know J&J vaccine is not going to be pre-positioned in states ready to go the way that the Pfizer and Moderna products were. If you remember, when FDA granted the authorization on those, they went ahead and shipped vaccine to states already while we were still waiting for ACIP to tell us, how to use them. That's not going to be the case with J&J. It's going to go through the whole process. At that point, we'll be able to place our orders and start receiving product. We don't know how much we'll get. Typically, based on our population, for every 1 million doses in the pool, we get about 15,000 of them. 1 million doses in the United States pool, we get about 15,000 of them. So that's just a best guesstimate on our part as far as what we might be receiving. J&J has committed to producing 100 million doses by June, is what they say. We are continuing to allocate our vaccine based on eligible population, just like we have done all along. So as we pick up this extra group, these people in 1B and these people 65 and up, the formula changes a little bit about where vaccines go. However, we also are continuing to use our social vulnerability index to make sure that we get those counties that are most vulnerable. If you're not familiar with social vulnerability index, I would refer you to CDC's webpage on that. It's a terrific explanation, but it uses a lot of different markers, such as just overall healthiness and access to care. It's a way of sort of measuring resiliency in a community, and as you might expect, some of our most disadvantaged counties are high on that scale of social vulnerability, and so those counties, which are not exclusively, but many of them are in the Black Belt, are things that we want to, are counties that we are prioritizing to make sure that we cover, regardless of the size of their eligible population. Now, we're not vaccinating people who aren't eligible in those counties, but we're making sure that they get every bit that they need to cover those counties. In terms of every other county in the state, we again are going to allocate that fairly based on eligible population, but there's just not enough to go around in any of our counties really. So we're going to make sure that we use the social vulnerability index to make sure we're protecting our most vulnerable people. There's a good bit of news from the federal retail pharmacy program that you know about. I think you're aware that Walmart's adding about, I think it was 17 sites or 18 sites, 17 or 18 sites. The original 74 sites they had, recall we had no input into those. We were just notified when the public was about where those were going to go. In this case, we were not asked for input, although we contacted them and said, we'd like to give you some input on where we think these locations ought to be, and we were trying to allocate them again based on our own assessment of social vulnerability and where we had gaps in our program. And Walmart, to their credit, mostly cooperated with us on that, and didn't have to do that, but we appreciate them taking our input and listening to us. And so they've already begun shipping to, I think, an additional 17 stores. Not large amounts of vaccine, only a couple hundred doses per store. However, Walmart also has received Pfizer product to do some larger scale clinics, and they actually began doing that this week. So these are 3 clinics that are trying to get out 1,000 doses, which they may be able to do in a day or so. They're not long-running clinics, but they are in Pike County, Coffee County, and Baldwin County. I think Pike and Coffee maybe have already even finished.
They're all today.
Oh, they're okay.
Let's clarify. They're all today.
Okay, all right. So they started that just a couple of days ago. We think that this may be something that'll go on for a couple of weeks. So we may have, 3 more next week or 3 more the next week. We're not sure about that. We again have given Walmart our thoughts about where the most vulnerable people are located and where we would like to see those locations. But ultimately, that's going to be their decision to make. So we'll let you know more about the next set of mass clinics when we get that. Additionally, CVS has been added by the feds to the retail pharmacy program. There were 9 stores, as you know, that were announced yesterday. This was a situation where we contacted CVS, asked for a call, and we told them we would like to put them in our high SVI counties. And we were really pleased that they were excited to do that. They were very cooperative. And so CVS is going to be administering vaccine in Camden, Evergreen, Greensboro, Bayou LaBattery, Jackson, Alabama, Lynette, Moulton, Tuskegee, and Union Springs. So the CVSs in those locations are all going to be part of the federal program. Remember, they get a federal allotment that's not part of our state allotment for that. We are still working to make up for the weather delays that we had last week. We worked with McKesson every day, all day, every day, to make sure that everyone gets caught up. I think all of last week's shipments have been shipped. There's makes a little bit of a delay for the shipments that should have otherwise come this week, but we're gradually working that out. Our county health departments are rescheduling people as quickly as possible. I just want to remind the public again that we have good data that if you're waiting on a second dose, waiting up to 6 weeks is not going to impair your ability to have a good immune response. So even though you may have supposed to have received it this week, up to 6 weeks will be perfectly okay. If you remember the mass vaccination clinics we had in 8 sites or the first part of this month, or maybe the end of last month, we have 6 of those are doing second dose clinics the week of March 1st through 5th. The 6 Pfizer sites will be doing second dose clinics March 1st through 5th. The other 2 Moderna sites will have mass vax clinics the next week for second doses. Let's see. I wanted to mention to you the UK variant. We still have a number of those cases that have been identified in the state. We have this number says 22. I believe that number is a little bit higher. In fact, right now I think we had some more identified last night. This is going to be an issue around the country. As you know, I think most health authorities expect this will be the dominant strain in the country very soon, probably by the end of March. And so we are continuing to monitor that situation. We partner with several different private and commercial labs to do genome sequencing. CDC continues to do surveillance on samples that we submit to them as well. And so we'll let you know more about that as we find out. As we've told you many times, we don't think that this is a variant that causes worse disease, but it is much easier to spread. And of course, the more people who are infected, the more overall hospitalizations and deaths are going to result. So please remember that we will have enough vaccine for everyone. Everyone who wants a shot is going to be able to get a shot, but we still have a little ways to go until there's enough to go around. In the meantime, you can keep yourself safe and your loved ones safe by following the advice that we've been trying to give for a year now. Please remember to stay home if you can. If you cannot do that, please wear a mask when you go out and stay away from other people. Please try to avoid gatherings of people indoors for long periods of time, especially people from other households. Please remember washing your hands and good sanitation and hygiene. Those things are all more effective than vaccination if you can do them successfully. So please don't forget to do that. On our race and ethnicity data, we're posting that each day on the website, and I encourage you to look at that. We have now given a vaccine to about 12.4% of it has gone to African Americans. Our goal is certainly much higher than that, although that's more than twice the national average. About 54% has gone to white Alabamians. Still, about 31% is not reported or is listed as unknown, and so we're still trying very hard to figure out ways to collect that data. Ongoing, I think that unknown number is going to go down. We are requiring that for people to put in, but we still don't always collect that. Alabama as a whole has done a great job. The past 5 weeks, we've given out well over 100,000 vaccines, and last week, even with all of the weather delays, it was our second best week that we have had so far in terms of the number of doses that we've given. As of last night, we have about 839,000 doses that have been entered into imprint by our providers. Interestingly, if you look at CDC's site, they actually have more than that because they're collecting information from these federal programs that are supposed to be reporting to us, but sometimes are a little slow in doing that. So we know that our numbers are actually a little higher than that. That correlates to about 77% of all the doses in the state have been given so far. To the best of our knowledge, all the remaining doses are scheduled for someone, have someone's name on them. So we're very, very pleased about how we're doing. I think the New York Times had us 45th this week. That's certainly not good enough, but it's ahead of a lot of our neighbor states, and we're very proud of the job that people are doing to get the vaccine out. So I guess I'll just stop right there. We'll be glad to take some questions and talk about whatever you like. So.
I have one question, Dr. Harrison. You kind of spoke on this earlier, but in some communities, just kind of working around some of the rumors and apprehension about these vaccines, Johnson & Johnson around the corner, what do you tell to people that want to pick and choose between vaccines or have been led to believe that one is better than the other?
Yeah, please don't believe that story. That's a rumor that's untrue. These vaccines are equally effective in preventing serious illness or hospitalization or death, and that's ultimately what we're trying to do. We are not nearly so concerned about cases in which people aren't really sick enough to be considered sick. So there's not enough vaccine to go around for people to pick and choose right now. If you have an opportunity to take any vaccine, no matter what it is, that's the one you should take, because you don't know when your next opportunity will come around to take a vaccine. There's just not enough. So please don't delay. If someone offers you one of these 3 vaccines, once we get the 3rd one made available to us, please take it, because it will keep you from getting sick. It will keep you from being in the hospital. It will keep you from dying. All 3 of them equally, no matter which one you receive.
Dr. Harris?
Yeah.
Okay.
Dr. Harris, on that comment there, for people who have had the vaccine, who've had the virus before and was sick, and you get the vaccination, let's say you get the one shot Johnson & Johnson, does that kind of compound the effectiveness of that, or is it just rumor?
Yeah, I don't think we know for sure, but it would make sense that you do. I think people who have had natural infection, we know have immunity. We don't know quite sure how long that immunity lasts, but you certainly have some immunity. The vaccine products, of course, stimulate your immune system a little bit differently than natural infection does, and so you develop additional infection-fighting abilities, based on taking the vaccine. So, by all means, I think it's really important to emphasize. We try to keep saying this every time we think about it. If you've been infected before, that is no reason to not get a vaccine. I mean, you absolutely should get one if you're otherwise eligible. If you're infected now, we want you to, wait till your 10 days of isolation are over. We want to make sure, just like any vaccine you would get, that you're not currently sick, you're not having fever. But otherwise, you're eligible to get it. We have said some things before about waiting 90 days if you've been infected. And that's only because you probably have protection on board. You're probably not going to get reinfected within that 90 days, and that just lets somebody else take your place in line who may be at risk, because they don't have any antibodies on board. But in fact, if there were plenty of vaccine to go around, there's no reason to wait 90 days. As soon as you're well and able to take it, you should take it, even if you've been infected.
Dr. Harris, Jeff Elias up at Channel 13 in Birmingham. I hope you can hear me okay.
Yeah.
Couple of things. we had a PhD talk about herd immunity at UAB yesterday, saying that might be possible by the spring. I'd like your definitive answer on that, and then, if you don't mind, since I don't want to take up everybody's time, I'd like you to clarify the groups once again. Those of us in the media are in 1C, but again, you have to be, I presume, over 65 or have underlying conditions. And then the third thing I would ask about is the discussion by Pfizer to add a third vaccine dose that came out today. I might have presumed that would be true for Moderna and Johnson & Johnson, that this would be the same dose. If it proves you have longer immunity, this would be wise to get this third thing somewhere down the road. The herd immunity is a particular concern to our viewers in Birmingham.
Sure. I had the opportunity to kind of see the work that Dr. Judd did. It was circulated a few days ago for us to get impressions of. I think she did a tremendous job. I certainly wouldn't claim to be somebody that can definitively speak on the work that she's doing. She does a terrific job. Dr. Judd is a great researcher. And so I think that what she put together was very intriguing and makes a lot of sense. And I think, her own study said this is a range of times when we might see herd immunity, and it could be as soon as, I believe it said May, but it might be as late as October. So, with any kind of prediction, you have to make certain assumptions. At least in the iteration of the report that I saw, she was very clear about the assumptions she was making and what she was not able to address, like, for example, the emergence of variants, or the addition of more vaccine with a new product like J&J. The last time I saw that paper, those things were deliberately omitted because we just didn't have enough information. So I think with any prediction, you just have to understand there's limitations to what we're able to predict. But herd immunity would be terrific. Go ahead.
Follow up on that, I guess. Right, excuse me for interrupting. But I think the sense that I've had from Dr. Fauci and others is that this is going to require 70% of us, as a minimum, to be inoculated, and we're nowhere near that. So to me, there's sort of a conflict there that I don't fully understand.
Yeah, I think that the number 70% has been thrown around a lot, but that's purely a calculation as well. We don't actually know where that number is because we've never been there. And I think 70% of people being vaccinated may not be precisely right. It may be 70% of people have an immunity so that the disease doesn't spread. And of course, we certainly have a number of people that have immunity because of natural infection, and we're not even certain what that number is because many people are infected, relatively asymptomatically, or they don't come to medical attention, and so we don't even know about them. I think right now around a little over 10% or so of our state we know has tested positive and has been infected, but certainly the percentage that has antibodies on board is a lot higher than that. So again, I would just say there's a lot of assumptions made there. Dr. Judd, I think, did a great job and acknowledged that there's some limitations to making those kind of predictions. So in regards to the second point about who's in which group, phase 1C, as you know, includes people who are 65 and up. We have already added that group in Alabama, but it includes people of any age that have certain chronic health conditions. There's a list of on CDC's website is the easiest place to find it, but it tells you those chronic health conditions that predispose people to poor outcomes. Now, there are many chronic health problems and that we're unfortunate and that we want people to eventually get vaccinated for, but we're particularly including those health problems that we know produce worse outcomes with COVID-19 infection. And that list is something you can see there. The phase 1C also includes a lot of these critical workforce workers that are not included in the 1B list. The easiest way to think of that is that among these critical workforce, the people in 1B are by and large people that just can't really socially distance, or they can't wear a mask, or they, or it's very challenging to do, or they, so on. The 1C group are people that are part of the critical workforce, but in a lot of cases are able to socially distance or able to wear masks consistently and so on. Those are, ultimately those designations don't apply to everybody and with every job title. There are people who are, in healthcare who we've been trying to get to in 1A, and yet some of them do telemedicine from home and never encounter another person, and so we're not including that group of healthcare workers in 1A. So just remember, your risk is what determines where you are on the list. It's not your job title. The final question about additional shots. I saw what Moderna has said. Pfizer has not spoken to that yet. I know that they're studying that. I think we need a little bit more data to speak about any individual vaccine, about whether there's going to be an additional shot needed or whether there's going to be an entirely new vaccine product that's needed. We just don't know that yet.
Couple questions, Dr.
Dr.
Harris.
Yeah,
Harris,
just,
news in Mobile.
I'll get you next.
Sorry, I just,
Go ahead.
what is your thoughts on the prospect of making the vaccine mandatory, either at the private company level or at a municipal level for certain groups like police and firefighters? It doesn't seem like anyone's really moved in that direction because of the supply issues, but as the supply grows, there's going to be a push in some places for that. What's the legality of that, as long as these vaccines are operating under emergency use authorization? And aside from the legal hurdles, is it a good idea to mandate it to get those numbers higher for certain groups?
Yeah, I'll do my best on that question with the caveat that I'm not an attorney and I'm really not trying to offer a legal opinion, because I will not do that correctly. But I think that some of the questions that have been raised are this. We're dealing with vaccines that at this point are not actually approved. They've been authorized for emergency use only, but they have not been fully approved in the way that other types of drugs and medical devices and vaccines work through the whole FDA approval process. And so I think a lot of us would have concern about a requirement for a vaccine that's not yet even fully approved. There's a big distinction to be made too between what private employers can do and what government is going to do. The state health department has no intentions of mandating vaccination for anyone. The state health department does not mandate vaccination for anyone. Schools, for example, can mandate that kids who want to come to the school have a certain set of shots, or else have an exemption for those shots. The state health department does not mandate that. We say what shots people should get, and we allow people to have exemptions in certain cases if that's appropriate to do so. But ultimately, people aren't made to take shots if they don't want to take shots. Again, a private employer, this is just me speaking as a non-attorney. I think private employers can make those kind of requirements of people if they choose to do so. I think so, but I've not heard of anyone being willing to do that at this point. Let's go here in the room. So,
Dr. Harris, off that point there, talking about the unique ways all these vaccines have been developed and the speed, and you didn't predict anything a year ago or 8 months ago, but just looking back on that time, how do you characterize the speed and getting it this fast? And secondly, now that it's somewhat available, becoming more available, people really want to get the shot yesterday. So how would you advise people to continue to try to get appointments and get in line as they are able?
Yeah, to the first point, these vaccines really have come on the market in a really quick way, and I think that's just one of the true miraculous events of my lifetime. The fact that we went from a disease that was unknown a year ago to developing vaccines within a few days of identifying what the virus was, and now we have them available and the millions of people have gotten them. That's remarkable. That's like going to the moon, or or some other fantastic scientific achievement. We like everyone else, had concerns about the process and whether it was being done correctly and safely, and so our staff began talking to government officials, federal government officials, way back in the summertime when these trials were underway, so that we could understand and be comfortable with the process. And we are totally comfortable with what was done. There were not shortcuts taken with regards to safety. There were a lot of things that were done a lot more efficiently, a lot of administrative processes that were done in parallel instead of being done one at a time in sequence like you would normally see. And I think the other point that gets lost a lot of times is, even though these are new vaccines, and even though mRNA vaccines haven't been used before, the technology's been around forever, and for decades at least, and lots of people have lots of experience with it. We have a lot of idea about how to work these vaccines, and so they were made so quickly because it's something that scientists know how to do. I mean, it's not a brand new concept that they just designed on the drawing board. So With regard to that, it did happen really quickly, but you can see how it all went exactly like it should go. And what we're really grateful for is that the vaccines really did work. I mean, it's possible all that work could have been done and they were just ineffective vaccines, but in fact, they're very effective vaccines. In terms of getting a shot, please persevere. Everyone who wants a shot is going to get a shot. We're going to have enough for everyone who wants it. And there's just not enough yet to go around, but continue to check with those providers that have shots, continue to check our website, continue to check with these retail pharmacy programs that have it, talk to doctors and clinics and pharmacies and urgent cares in your community that have the vaccine. All those sites that have received vaccine are on our website, on the map on our website, and people can find those locations there. We are working very hard to get people on a very predictable cadence of allocation so that they know exactly how much they're going to get each week or each month. That'll make it a lot easier for people to plan and schedule. And as we add more vaccine to the pool, of course, there'll be more available for people to get.
Dr. Harris, this is Morgan Hightower with Fox 6 in Birmingham. Just a quick question for you about allocation. So if we're looking at the data from the time you got the very first vaccine to now, there should be 1.5 million doses, second doses of both vaccines for Alabama allocated. Obviously, the number that's on hand is lower. So can you just explain that difference there? And then also tell me, is Alabama ordering every single dose allocated to the state?
Sure. So the allocation number is essentially the check in the ledger that tells the check mark in the ledger that tells how much Alabama is entitled to receive at some point. When first doses are given and those are entered in the system and orders are placed, Alabama immediately gets an allocation that goes up by that number of first doses. But those doses aren't going to arrive here for 3 weeks in case of a Pfizer product or 4 weeks in case of a Moderna product. So the allocation just says this is Alabama's percentage that you're entitled to receive at some point. But not all those are shipped they're not shipped for 3 weeks or 4 weeks later. And so that's why the allocation number is always higher than the number of doses we actually have here in the state. I think there's a small discrepancy in how many were allocated and how many have actually been ordered. Sometimes the order for a second dose can take a little bit longer to get in and process, but we're, I know we're ordering more than 99% of our allocated doses, which is as good as any state is doing. It's just a small difference, but we absolutely intend to get every one of those as quickly as we can.
Dr. Harris,
Dr. Harris,
I'm sorry, let me got one in the room first, and then we'll go to you on the phone. Thanks.
I had a citizen ask me earlier this week something about another rumor, so to speak, appearing and having to pay for a vaccination or possibly having to pay later down the road. What could you tell the citizens that are still kind of in the dark and have these rumors going around about having to pay for this federally funded vaccination program? Sure.
There is no cost to any person for this vaccine. No cost passed on to the recipient of the vaccine. There certainly should not be. We have heard of about, I think, 2 cases total so far where a provider was attempting to charge, and we have shut those down so that they're not able to give vaccine anymore. If anyone's doing that, please let us know that, because we will stop that from happening. It's true that the providers are able to bill insurance for the administration cost. If somebody has insurance, or if someone doesn't have insurance, the provider can bill HRSA, the federal agency, that will pay an administration fee, and that allows the providers to make sure they're able to cover their own cost and time, and give it to anybody who needs it, regardless of ability to pay. There are no costs like copays or deductibles involved that would be passed on to the consumer. So if that's happening, we want to know about that. Let me go to the phone there. There was a question there.
Hey, Dr. Harris, it's Kate Swift with 48 News in Huntsville. I just wanted to, I don't know if I misunderstood, we're in phase 1C, and 65 and older, and then there was something about those with health conditions. Did you expand the eligibility to those with health conditions?
No. I think if I understood that question, we are vaccinating phase 1A and phase 1B. Also, last week on Monday, we included persons 65 and up from that 1C category. You may remember we did something similar earlier on. We were in phase 1A, which were healthcare workers and also nursing home residents, and then our next group we actually dropped down to 1B just to get the 75 and up, without including all of the jobs and other descriptions that were included in 1B. Eventually, then last week we added all of 1B, and we dropped down to 1C only for the group of people that are 65 and up. We have not added the other job titles that are included under 1C, and we've not yet added the people with chronic health conditions under 1C. I will say, we've heard from many of those people, and it's really heartbreaking to try to respond to them that we just don't have enough vaccine right now. People with chronic health problems absolutely deserve to be vaccinated as soon as possible. We are making every effort to get there as quickly as possible. The barrier has been that in Alabama we're an unhealthy state, at baseline before COVID. And when you add that group of people that have diabetes and heart disease and obesity and chronic lung disease, those things that put them at high risk, you have more people than we're trying to vaccinate now. You have more people in total that you're adding. You're more than doubling the size of the group of people. And so it's just not fair to tell that group of people, okay, now you're at the front of the line when there's no additional vaccine coming into the state. So we, my heart goes out to people who are waiting patiently and who have health problems and who are wondering when their time's going to come because they're just not old enough yet. We're going to get to them as soon as we possibly can.
And when you do open that up to those with health conditions, is it going to be it's open for everyone with a health condition, or do you plan to open it up for those with heart conditions and then those with diabetes and kind of work down the list?
Yeah, so it's not likely to be for anyone with any condition, but as we were kind of referring to earlier, there are a list of chronic conditions for which people are at higher risk for disease or higher risk for serious illness. That was a list that I referred to that you can probably more easily find on the CDC website. But I guess I haven't thought through that, but chances are it'll be that entire group. I think it's really challenging to parse through that and pluck out one condition, but not include another condition. So I think we're very likely to include them all at once. I guess I just hadn't really thought of that before.
Dr. Harris, I had a follow-up question about the social vulnerability index that you were referring to earlier.
Yeah.
And in an attempt to reach vulnerable populations. Tell me more, is that the product that the CDC produces? What specifically are you looking at, and what specific steps are you taking to reach those areas, given the fact that the eligibility requirements are the same?
Sure. So the Social Vulnerability Index is a federal calculation, and you can find it in a lot of places. But I think we tend to use the CDC's website because that's a measurement tool that all states are using or trying to use to make sure we get the most vulnerable people. We certainly can put you. We can help you find that website if you have any trouble locating it. But it's just a part of CDC's CDC's overall website, not necessarily for COVID. What we are trying to do is, I will say that our most vulnerable counties typically are very rural and actually are typically very small. They don't have really large populations. And so what we are making sure that we do is that we go out of our way to recruit additional providers in those communities to make sure there's other places for people to get the vaccine. We're making sure all our county health departments are giving vaccines actively in those counties. Right now we're doing that in every county, but we're particularly making sure that we allocate enough to cover the eligible populations in those counties as well. We've tried very hard when we get these other things like the federal retail pharmacy program to recommend that they go to these areas that are most vulnerable. Our recommendations are based strictly on the SVI in terms of who we've tried to get cooperation from the chain pharmacies to go to, and so far they've been willing to do that. And then these will be the places that we target other efforts when we have the ability to do larger scale clinics. We'll do that. We are trying to find a way to do mobile clinics on a small scale And these will be the counties that we target in particular when we have the ability to do it.
And is that just looking at the county level, or are you looking at the high vulnerability areas within counties that overall might not be?
The best data we have is county level data. I will tell you, in every county in the state, we have disadvantaged populations. No matter how affluent the county, our county health departments are aware of that. We're focusing our efforts just based on their local knowledge of their communities, on where people have a hard time with transportation, or where people don't have other options. So we don't have a hard numerical formula for within a county. We just don't have that granular a level of data. But I will tell you that that's what our administrators do at the county health department level. They know where people are in need, and that's who we're trying to reach out specifically, even though the SVI is actually a county level statistic. Yeah.
Doctor, you mentioned we all have a lot of questions, media and just general population, but just in your realm, in your world, and the scientists and those that are working outside of the administrative stuff, on the science stuff, what kind of questions are going between yourself and doctors like yourself in that that maybe beyond ours, just part of the science? What kind of questions are out there, and do you guys talk about?
There's a lot of great science happening, and we're all kind of trying to uncover this as we go along. There are so many things that are unknown right now. So, for example, what's the role of monoclonal antibodies? And we have them available, and we know how to use them, but how does that affect your ability to be vaccinated, for example? What do we do with people who are vaccinated, who then become ill and they don't get well for a long time, and we're not sure? Can we go ahead and give them a monoclonal antibody even though they've been vaccinated, and how does that delay their second shot, for example? There's a lot of really technical issues that are beyond me, that conversations I've been a part of but don't really contribute to, about providing critical care for these patients, and when are certain interventions warranted. A pretty common one that's easy to understand is the role of steroids in COVID-19. Steroids are very effective. Dexamethasone is very effective in treating people with serious illness, but not if it's given too early. If you blunt the body's immune system too early, then they don't do as well. And so, steroids are typically given on day 8 or 9 of illness, but you don't want to do it sooner than that. And there's certainly a lot of strategies about how do you ventilate these patients, and how can you put off ventilation as long as possible. And then some, extremely technical things that are beyond my training about caring for these seriously ill patients. So there's just a lot of really interesting medicine, a lot of unknown questions, and a lot of discussion going on all the time about them. All right. Anybody have anything else?
Thank you so much.
Okay, sure. Thank you, guys. Thanks for calling in. We appreciate it. We'll try to do it again next week. Thank you for joining us.
Yeah.
Thank you, guys. Appreciate it.